Hey guys. So for our family and child class that we do, the OB and Peds, we have 4 chapters to get through for this week, which is kind of a lot. So I'm going to go ahead and do some recordings for you on these, and we'll see if we can get a better understanding of kind of what's going on with some of this stuff. So the first one is chapter 6. So we'll go ahead and get into that a little bit. All right, so this has to do with growth and development. So in this chapter, it says we're going to describe general principles of growth and development. We're going to discuss cognitive growth development according to Jean Piaget. We're going to discuss psychosocial growth and development according to Erik Erikson. We're going to discuss psychosexual growth and development according to Sigmund Freud. We're going to discuss social moral growth and development according to Lawrence Kohlberg, and discuss the theory of nature versus nurture, apply principles of family-focused care and approaches toward the child, analyze factors that affect growth and development, and understand nursing applications of growth and development theories. Okay, so go ahead and get started here. So growth and development are closely interrelated and interdependent processes that are unique for each individual and influenced by factors such as genetics, the environment, and also their nutrition. Growth and development follow an orderly pattern characterized by periods of rapid growth and plateaus. So the chapter gives a couple of definitions. There's something called cephalocaudal, which starts at the head and moves down. So for an example of this type of growth pattern, it would be a child can control his or her head or neck before they can control their arms and legs. So that would be cephalocaudal growth and development. Proximal distal is where it starts in the center and processes to the periphery. So for example, movement and control of the trunk section of the body occurs before movement and control of the arms. All right, so I know you guys took a growth and development class, but we're going to go ahead and just kind of refresh your memory a little bit about Piaget and some of these other people. So development is a sequential and orderly process moving from stages that are simple to more complex. That's what Piaget thought. A child must accommodate to new or complex problems by drawing on past experiences. And there can be overlap between the child's age and stage of development. Each stage does not start at and end exactly at the same age for each child, so everyone's a little bit different. So with Piaget, he came up with this theory of cognitive development where he came up with these different stages. So in your book, it talks about what happens in each one of these stages. So first of all, one of the first ones is sensoromotor. So sensoromotor starts from birth to 2 years, and this is where the child learns through motor and reflex actions. And they begin to understand that he or she is separate from the environment, from others. In the sensoromotor stage, there are stages in that even. So the chapter kind of talks about that a little bit. Then you go from the sensoromotor stage to the pre-operational stage. This is between 2 and 7 years old. This is where you start to apply language, use symbols to represent objects. You can think about things and events that are not immediately present. Your thinking is influenced by fantasy, and teaching must account for the child's vivid fantasies and undeveloped sense of time. So after the pre-operational stage, then comes the intuitive thought stage. This is from 4 to 7 years old. And then you go into the concrete operational stage. That is going to be from 7 to 11 years old. In that phase, you show an increase in accommodation skills. Development happens with the ability to think abstractly and to make rational judgments about concrete and observable phenomena. So with teaching, you need to get the opportunity to ask questions, to explain things back to the nurse. This allows the child to mentally manipulate information. And then the last stage is formal operational stage. So this goes from 11 years old to adulthood. In this stage, you bring cognition to its final form. So the individual no longer requires concrete objects to make rational judgments. Individuals are capable of hypothetical and deductive reasoning, and teaching for adolescents may be wide-ranging because they can consider many possibilities from several perspectives. So that's kind of where Piaget brings it all together. For you to review his whole theory and stuff, in your book, it's page 82, table 6-3, talks all about his different things going on with his theory. Okay, so the next person we're going to get into is Freud. So remember, Freud is known for his psychosexual theory. It's based on the belief that experiences from our childhood form the unconscious motivation for the things we do later in life. The theory proposes that sexual energy is stronger in certain parts of the body at specific ages. Sexual feelings are present in different forms depending on age. Fixation of development can occur at a specific age if needs are not met or conflicts are not resolved. Freud's theory views the personality as consisting of three parts: the id, the ego, and the superego. The id is the basic sexual energy that is present at birth and drives the seeking of pleasure. The ego is the realistic part of the person, which develops during infancy and searches for acceptable methods to meet impulses. And the superego is the moral and ethical system that develops in childhood and contains values as well as conscious thoughts. So according to Freud, people have two sides, human nature. So you have rational intellect and you have irrational desires. So rational intellect is being able to think about others and do what's right, like delayed gratification. And then irrational desires is following the unconscious mind, which is driven by uncontrollable instincts that are irrational and pleasure-seeking. So with his stages of psychosexual theory, he has the oral stage, which is birth to 1 year. Children in this stage are preoccupied with activities associated with their mouth. So sexual urges are gratified with oral behaviors like sucking, biting, chewing, and eating. Children who do not have their oral needs met may become thumb suckers or nail biters. In adulthood, they may become compulsive eaters or smokers. Normal development requires not depriving oral gratification, such as weaning too soon from a rigid feeding schedule. The next stage is anal. This is 1 to 3 years of age. So in this stage, kids are preoccupied with the ability to eliminate. Sexual urges are gratified by learning to voluntarily defecate. The sphincter muscles are maturing. So this is like where you could do toilet training and whatnot with this kid. Then the next stage is the phallic stage. This is from 3 to 6 years old. This is where the kids are preoccupied with their genitals. They're curious about childbirth, masturbation, and anatomic differences. Girls experience penis envy and wish they had one. Boys suffer from castration anxiety, the fear of losing the penis. Children develop strong incestuous desire for the caregiver and an opposite gender. And then the next stage is your latency stage. This is 6 to 11 years old. So sexual drives are submerged, energy is focused on socialization and increasing problem-solving abilities. Appropriate gender roles are adopted, and then the superego is developed to a point where it keeps the id under control. And then the next stage would be the genital stage. This is between 12 years of age and it lasts till adulthood. So with this stage, they struggle with their sexuality. Sexual desires return and are related to physiological changes and fluctuating hormones. They deal with the struggle of dependence and independence issues with their parents. They learn to form loving, appropriate relationships, and they must manage sexual urges in a socially accepted way. So that's kind of where Freud's theory takes place here. Okay, so the next theory is about Erikson, Erik Erikson. So he had the psychosocial development theory. So his theory consists of 8 different stages that address development over the lifespan. Each stage has a crisis that exists. A healthy personality development occurs at each crisis. A challenge between the ego and social and biological processes is resolved. And a person must master these psychosocial crises to grow and progress to the next stage. An individual either meets the healthy needs or they don't, and this will influence future social relationships. So with his, we've got trust versus mistrust. This is from birth to age 1. This is where the child learns to trust as needs are met by the caregiver. So some of the stuff the book says, if the sense of trust is developed, the infant will see the world as a safe place. Play is usually considered a psychosocial activity. During this stage, play is referred to as solitary. The next stage is autonomy versus shame and doubt. This is kind of toddler years, so age 1 to 3. The child becomes more independent. They have the frame of mind that they're a big kid now, and the child starts to have some control over their bodily functions. So they vocalize by saying no to something and direct their motor activity. Children are constantly criticized for showing independence and autonomy. Children who are constantly criticized for showing independence and autonomy will develop shame and doubt in their abilities. And then toddlers also need to recognize the feelings and needs of others. Excessive autonomy could lead to disregard for an inability to play with others. So that's something to think about in that stage. Okay, so then we get into the preschool stage, age 3 to 6 years old. This is initiative versus guilt. So in this stage, they start to develop their conscience. They learn what right from wrong is. So they learn about the environment through play. They learn new responsibilities and can act based on established principles. Play at this stage is known as associative play. All right, and then the next stage is going to be in industry versus inferiority. So this is school-age kids from 6 to 12 years old. So in this stage, they learn rule-following behavior, they form social relationships, and they're seen as very important to them. Okay, so now the child develops different interests and they take pride in their accomplishments. They enjoy working in groups and forming social relationships. They like to do projects, those are enjoyable for them. A child must learn balance and understanding that he or she cannot succeed at everything and that there's always more to learn. And play during this stage is known as cooperative play. All right, and then the last stage is going to be identity versus role confusion. This is the adolescent from 12 to 19 years old. So children of this age are preoccupied with how they are seen in the eyes of others. They're working to establish their own identity. They're trying out new roles to see what best fits them. If they are unable to provide a meaningful definition of their self, they are at risk for role confusion in one or more roles throughout their life. Some confusion is good and will result in self-reflection and self-examination. So in this stage, changes in their body are really great. they're preoccupied with their appearance and what others think of them. Peers are very important, and they work on establishing their own identity. Okay, so then there is a theorist called Kohlberg. So Kohlberg, he theorized that children acquire moral reasoning in a specific developmental sequence. So he developed a stage-based theory that established on the premise that at birth we are voids of morals and ethics. Thus, moral development occurs through social interaction with the environment around us. So he says that moral development, which occurs in 3 major levels, and it can be advanced and promoted through formal education. So with him, he has this pre-conventional level. This is where probably you're age 2 to 7 in this one. You follow rules that are set by those in authority, and you adjust your behavior according to good or bad or right or wrong thinking. So some of the things in this stage, obedience and punishment orientation, and then also individualism and exchange. The next stage of his theory is called the conventional level. This is kids 7 to 12 years old. In this stage, you have good interpersonal relationships and you maintain the social order. So you seek conformity and loyalty, you follow rules, and you maintain social order. And then the third stage is the post-conventional autonomous level. This is kids 12 years and older. They have social contact and individual rights. They use universal principles. They construct a personal and functional value system independent of authority figures and peers. So that's what his theory is about. So which theorists reasoned that cognitive development is a sequential and orderly process moving from stages that are relatively simple to more complex? This would have been C, Jean Piaget. Okay, so this kind of gets into a little bit about nature versus nurture. So let's see if we can talk about that. Okay, so with nature versus nurture. Nature refers to the traits, the capacities, and limitations that a person inherits from their parents at conception. So examples would be things like hair and eye color, body type, inherited diseases, and then maybe they could even be athletic because their parent was, or maybe they have muscular ability. You know, all of those things are kind of nature. And then nurture is going to refer to environmental influences that occur after conception. So this includes the mother's health before birth and the child's environment thereafter. Nurture takes what nature gives us and molds us as we grow and mature. So the interaction between the two is a critical influence in our development. So like your family, that's going to influence how you are. So how your parents are, and you know, if they stayed together, if they got divorced, whatever, that's going to affect you. All right, and then, so this gets into a little bit about the family. So the nuclear family and the non-nuclear family. So the nuclear family is composed of a mother and a father, a biological or adopted child or children. The term non-nuclear family describes family other than traditional, such as single-parent homes, grandparents functioning in a role of parents, same-sex parents with children, and blended families in which families from divorce are joined together by remarriage. This can occur when a spouse has died and the remaining spouse remarries. Okay, so then we talk about behaviors and social learning theory. So um, when we talk about this, this describes the importance of the environment and nurturing of a child. So the behaviorist theory was the dominant view from the 1920s to the 1960s. Watson and Pavlov and Skinner, that's where all of this came into play, which I'm sure you remember learning about all of them. So they talk about this theory is based on observable things. So classical conditioning, this is a learning process that occurs through associations between the environment and a naturally occurring stimulus. And then operant conditioning is a change in behavior based on rewards, reinforcement, and punishment. So, maybe you threaten your kid with something, and so they change the way they do something, because they were threatened. Or maybe you say, hey, if you get an A in your class over these next 8 weeks, I'm going to give you $10. And that would be another way of doing operant conditioning. All right, so the next slide here talks about social learning theory. So Albert Bandura is part of this. So he completed the famous Bobo doll experiment that demonstrated the power of observation. So when children observed violent acts, they mimicked them. When an adult was praised for those acts, the children were more likely to repeat them. Bandura's theory said that children learn through observing others in their environment, as well as from rewards and punishments. Intrinsic reinforcements such as satisfaction and accomplishment lead to learning. Through observation, the actions of other people, children develop new skills and acquire new information. Okay, so factors that affect growth and development. So intrauterine factors. So the mom's health and nutrition status while pregnant is going to affect the fetus big time. So some of the things intrauterine that would affect the baby would be poor nutrition, can lead to low birth weight babies as well as slow development. Low iron levels in the mother can result in anemia of the infant. Maternal smoking can result in infants with low birth weight or congenital abnormalities like cleft lip and cleft palate. If you drink during pregnancy, it can lead to developmental delays and fetal alcohol syndrome. And then prescription and non-prescription drugs may also affect the unborn child. Sometimes if a mom gets sick during pregnancy with some kind of illness, it can harm the fetus, such as rubella. And then exposure of the mother to environmental factors like chemicals or radiation can also harm the fetus. So premature infants can experience delayed growth and development, and they're expected to reach developmental milestones at the same age they would have reached them if they were born at a gestational age. So age is adjusted for assessments. You're going to subtract the weeks and the month that the infant was born premature from the current chronological age. The child should be reaching the adjusted age milestones. Most premature children have caught up with all the milestones developmental tasks by age 2. Like I know my one niece was born premature and she was slow at doing everything because she was so immature. And she's kind of still is, even though she's 5 now. Okay, chronic illness and hospitalization. So illness and hospitalization are definitely stressful events for the child and the family. A child's physical state of well-being can affect the developmental levels because illness may interfere with normal progression by causing childhood delays and acquiring the skills needed to progress to the next level. When a child is hospitalized, the family routine is disrupted. The possible separation of family members because of the child's illness also adds stress. And then this mentions environmental factors. Children who are abused or neglected experience problems in numerous areas of growth and development. Abuse can be physical, including beatings, burns, or other physical injuries. areas that are considered neglect include not providing common medical care, not allowing a child who is ill to consult a healthcare provider, death of a child from an illness that is considered treatable. Emotional things would be not attending to the child's emotional needs, ignoring the child, leaving the child alone for significant amounts of time. Educational things would be not providing education for the child in any manner at all, not providing the child needed aids to encourage education, like maybe they need glasses or hearing aids or something and you just don't get them. And then abandonment is leaving a child to care for him or herself and not providing adequate adult supervision. So definitely environment is a big deal for kids. Whoops. Okay, so then this gets into Maslow's hierarchy of needs. So Maslow's hierarchy of needs is super important for you guys to understand and really know, because it actually helps you be able to answer certain priority type questions that are on the NCLEX. So really make sure you pay good attention to this. Okay, so basic needs at each level of someone's life must be met before they can progress to the next level of growth and development. So this is kind of outlined in how Maslow's hierarchy of needs is. So at that very bottom level of the triangle is your physiologic needs. They have to be met first. So food, rest, air, water, those are your basic needs. You have to meet those first. Level 2, the child has the need to be protected from harm and feel safe, so safety issues. Level 3, feeling loved and part of a group. Level 4, esteem needs to develop, the need to respect yourself and be respected by others. And then level 5 is self-actualization, or becoming a complete person and reaching your greatest potential. So that's self-actualization. So lack of income can affect a child's health and development. Families who are struggling to make ends meet may be unable to afford healthy food and lack of transportation to healthcare facilities. When both parents work, they may have little time to devote to meeting their child's emotional needs as well. Cultural background also influences how children are socialized and how they experience the world around them. Beliefs, customs, and values are learned from cultural surroundings. Everyone is a product of their cultural background. Culture does more than shape our preferences, it's the foundation of our worldviews. So definitely culture is going to affect how a child develops. Okay, this says blank refers to the mother's health and nutritional status while pregnant. This is going to be A, intrauterine factors. Okay, so again, in this chapter, it just talks about basic things having to do with growth and development with kids. So make sure that when you're going over this, you really refresh your memory on these different theorists like Piaget and Erikson and all of that. It's very important that you get those things down right now before you move on further in your nursing career. Okay, so that's that one. Our next chapter is going to be about newborns and infants. Okay, so in this chapter, we want to describe the perinatal factors that affect the newborn during the transition process. We want to describe growth and development that occur during the newborn and infancy period, describe the physical assessment approaches for a newborn and infant, discuss the variations in newborn procedures related to the care of the newborn and infant, and describe approaches to medication administration in the newborn and infant. Other things that we're going to do: describe the health promotion functions necessary in a newborn and infant family structure, discuss the emergency care of the newborn and infant, describe the specific characteristics of care of the hospitalized newborn infant, and also describe the specific characteristic of a pediatric medical home during the newborn and infancy period. And then we're going to discuss chronic care of the newborn and infant, describe the importance of function of play in the newborn and infant's life, describe the safety measures needed to care for a newborn and infant in the home, and discuss alternative and complementary therapies for the family of the newborn and infant, and then describe child abuse considerations in the newborn and infant population. Okay, so when it talks about caring for a neonate, a child younger than 28 days old is considered a neonate. The term newborn refers to any preterm, term, or post-mature child, and the infancy period comprises age 1 month to 1 year. All right, so when we talk about care associated with most full-term infants at 38 weeks gestation, primarily protects and supports the neonate during its physiologic transition to extrauterine life. So in other words, you want to try and get this baby to at least 38 weeks to give them a really good chance at life. And then as far as maternal history, you know, perinatal substance abuse is going to be a really big deal. If this baby gets exposed to that, then they're going to have a really hard time when they first are born. So substance abuse can affect the developing fetus through exposure to nicotine, selective serotonin reuptake inhibitors, benzodiazepines, alcohol, opioids, you know, any type of substance like that. It can all affect the baby. So biologic neonatal specimens are obtained from the meconium, hair, cord blood, and urine for testing to see if that's what their problem is when they come out. And you know, they are scored, and you can kind of see if they are affected by these things just with how they act when they come out. So yeah, so unfortunately, some of the things that can happen to them, they can have seizures, they can have weight loss, and some long-term complications from just this substance abuse that the mother may have had before the baby came out. Okay, so then this gets into transition to extrauterine life. So as the baby transitions from being inside the mother to coming out, there's a lot of things that happen to the baby. So the respiratory system goes through a transition, right? So once the umbilical cord is clamped and the infant takes his or her first breath, all body systems of the neonate transition to extrauterine life. But most significantly is the respiratory and circulatory system transitions. So, you know, you have to have like external stimuli, like just think about when we were in OB and we talked about when the baby comes out, you're worried about that first breath that this baby takes. You're worried that they have all this stuff in their nose and their air passages, so you're going to suction them out, and hopefully they start crying and taking their first breath right away. The other stuff, you're going to make sure that, especially if this baby is not born, you know, to term, that you're really going to probably have to give them oxygen and maybe even intubate them if that's the case, if they came too early. So the first breath begins to clear that amniotic fluid, and it fills the lungs with oxygen, and it dilates the pulmonary artery. This decreases the pulmonary vascular resistance and increases pulmonary blood flow and increases oxygen and CO2 exchange. So all of this starts to like newly wake up after this kid comes out. In your book, it does talk about some things about signs and symptoms of alterations in respiratory transitioning. So like if you were seeing some of these things, you would know there was a problem. So if you saw cyanosis, sure, you know, they're not pink, they're blue, that's a big problem. Apnea, gasping, deep, slow, irregular terminal breaths. If they had nasal flaring, excessive mucus or drooling, tachypnea, tachycardia, chest wall asymmetry, grunting, retractions, anything like that, that's going to be a problem. And then with the circulatory system, um, so once the cord is clamped and they take their first breath, you start to see some things happening. So the ductus arteriosus between the pulmonary artery and the aorta is going to start to change. The foramen ovale is the connection between the right and the left atria, and the ductus venosus in the hepatic system. All of these things are going to start like working newly since you've transitioned from being inside the mother to coming out. So these vessels are going to start, carrying blood through this little person's body so that they can have regular things happening now instead of, relying on the cord blood of the mother. So other things like as far as transitioning to being outside of the body, of the mom's body, would be thermal regulation. So we want to get this baby to not be like super cold, right? So we're going to try and warm the baby up and do what we can for that. And remember when we talked about signs of cold stress, we said things like grunting, pallor, lethargy, jitteriness, tachypnea, hypoglycemia. Some of those things might be happening if they have cold stress. So typically we're going to, put a cap on them. We're going to, do skin-to-skin contact with the mom, put them in a warmer, all of those types of things. Okay, let's see. All right, other things, the chapter also talks about kangaroo care a little bit. It's in a blue box in your chapter that you guys can read that. So it talks about the benefits to the infant and the mother. So it helps to stabilize the heart rate in the infant. It stabilizes their breathing, improves their oxygenation, decreases crying. And then with mother, it increases her milk supply. It increases her sense of parental control and increases bonding with the baby. So those are some other things. Again, if you have a mom who was diabetic and had a baby, then one of the things that you're going to be worried about right after they come out is the baby's blood sugar. So we're going to be watching that really closely as well. And then remember, signs of hypoglycemia in a newborn would be some of those same things we just already mentioned before. So you could have irritability, jitteriness, no tone to them, apnea, poor feeding, lethargy, and also seizures. So, and then when the baby comes out, we're going to be screening them for certain things, right? So they screen babies for metabolic disorders at birth. They say there's quite a few babies who actually do have an issue, so that's why they, do that right at birth. Some of the other things that we're going to screen them for, remember we talked about PKU in our OB stuff? That would be something they're going to get screened for. That phenylketonuria. That's a metabolic disorder that they test for. They're going to test for congenital hypothyroidism, congenital adrenal hyperplasia, galactosemia, maple syrup disease, Krabs disease, cystic fibrosis, and sickle cell disease. So those are some of the things they specifically will screen for. So make sure you're aware of what some of those things are if you don't know. All right. With physical development, we want to look at their height and weight, their head circumference, and their period of reactivity. All right, and then we also are going to look at cognitive development milestones. Um, so there is, sorry, I'm kind of going all over the place here. So with cognitive development milestones, some of the things that we would look for, give me 1 second. All right, sorry about that, guys. Let me go back just a second here. So with physical development, when we talk about height and weight, so with their height, they look at this chart that compares a child's measurements with those of other children of the same age. So the average length at birth is usually about 20 inches, and the best predictor of adult height is family history. So that's kind of how you would look at that. They also look at head circumference. The head and chest circumference are usually equal, with chest slightly smaller, usually 1 to 2 centimeters less than the head. If the head is smaller than the chest, consider microcephaly or small head. If the head is more than 1 inch larger than the chest, it can mean increased intracranial pressure or other issues. So that's kind of a big deal. With weight, so the average birth weight is usually about 7.5 pounds. And then they look at all of these different charts again with weight. So they tell you if you're like, where's it at? Anyway, they tell you if you're like in a certain percentile of all kids in that age group, you know. So like if I'm in the 90th percentile, that means that I'm bigger or I weigh more than 90% of the kids in my age group. So that's kind of something that they look at with weight. And then with reactivity. So initial period of reactivity, usually 30 minutes at birth. After birth, the baby's going to be really active and interested in the environment. They actually have their eyes open. They do a lot of things. And then remember, after that, they have this inactivity period where they sleep a ton, right? And then they have a second period of reactivity that's usually 2 to 8 hours after birth where they're alert and hyper responsive. So we kind of talked about that in our other class before. Okay, with cognitive development and milestones. All right, so with developmental milestones, we look at things that we should expect them to do at different times in their life. So infants achieve skills such as taking their first steps, rolling over, playing, speaking, and moving as they age. These skills are known as developmental milestones. And the timing and the appearance of these skills indicates whether the infant is developing at the normal rate for his or her chronological age. So typically, like when you take your kid to the doctor for their yearly appointment, they'll be like, oh yeah, for this, you know, time in their life, they should be doing this, this, and this, and they'll ask you specific questions about that to see if you're meeting those things. So for instance, like birth to 3 months. As far as like motor skills go, they say they're wobbly at first, but soon they can lift their head when they're on their belly. They can grasp an object, kick vigorously, and turn their head from side to side. They can get their hands and their thumbs to their mouths, and you know, hearing should respond to the parent's voice and respond to loud noises. You know, they look at all of those types of things. Then 3 to 6 months, usually they can raise their head and support it by 4 months. They can roll from their abdomen to their back so they can roll over. They usually sleep more stably now, so they have a more stable sleep pattern. They can sit when propped at 6 months. They can recognize familiar objects and people. And then at 6 to 9 months, they can roll from their back to their stomach to their back. They can sit unsupported by 8 months. transfer objects from hand to hand, put their feet in their mouth, all kinds of things like that. 9 to 12 months, they can drink from a cup. They know their name. They can stand alone for brief periods of time. They can develop security objects like a favorite toy or a blanket. At around 12 months of age, they can transition to whole cow's milk instead of using what you were giving them before. With cognitive development, this involves the infant's processing of information, their conceptual processes, intelligence, language development, memory, and perceptual skills. So they say primitive reflexes will disappear within months after birth and are controlled by lower brain functions. So they use scales like the Brazelton Neonatal Behavioral Assessment Scale. This tests an infant's neurologic development, behavior, and responsiveness. They have a couple of other ones, like there's a Denver Developmental Screening Test that sometimes people will do, but that Brazelton one's pretty popular. Okay, so then it talks a little bit about nutrition and sleep. Okay. So with nutrition, they talk about non-nutritive sucking. So this is a self-soothing or comforting measure used by infants. The infant's sucking ability is necessary for neurologic development and survival. A lot of kids will use pacifiers and fingers or fists. They say avoid using pacifiers in the early days of breastfeeding, and then never tie or clip the pacifier to the child's clothing because this can be a source of strangulation. And then with breastfeeding, so this is the optimal method of feeding because it provides necessary nutrients. Like we talked about this in OB. It's very helpful because it helps their immune system, decreases their risk for obesity. It's a good thing to do. When it talks about weaning, weaning someone from breastfeeding sometimes can be difficult. So one of the things they say is to eliminate one feeding at a time, observe for signs that the infant is having emotional or physical issues, and then also usually the last feeding to be eliminated is the nighttime feeding. So that's usually how that goes. With bottle feeding, they say breast milk is the recommended method for infant feeding. However, if a mother chooses to bottle feed her infant, never make her feel guilty for this choice, because a lot of people kind of feel that way. So when feeding a newborn formula, carefully dilute with water based on the manufacturer's mixing instructions. And then you have to make sure that you wash the bottles and the nipples, and use a dishwasher or boil all bottles, rings, and nipples so that they get clean. When you are giving a bottle to a baby, you never want to prop a bottle because this can cause choking. And then as far as advancing feeding in infants, so typically okay guys, so with advancing feedings in infants, so typically, usually when a baby is about 4 months old or so, they will say that you can start adding in cereal, like rice cereal, and then you start slowly adding in other things as far as solid foods. All foods, as they get a little bit older and you give them like actual little pieces of food, you should put everything on a spoon. You don't put anything in the bottle. Around 8 months or so, strained fruit, vegetables, and strained meats can be introduced. Um, Usually you introduce a single type of food for 2 to 3 days to observe if they have any kind of reactions like a rash or diarrhea or abdominal cramping or vomiting from it. That way you'll know if they have any kind of allergies or something. And then as far as choking prevention, that's something to really make sure you understand. Um, Foods that can result in a decreased risk of choking in the infant include um, cooked macaroni, small pieces of cheese, soft cooked vegetables like potatoes, um, grapes cut and force. So like there's ways to prevent, choking. You just have to be very careful. With sleep, unfortunately, there's something called sudden infant death syndrome that we have to worry about. So we tell parents to make sure they put their infants on their backs when they sleep instead of on their bellies. So we're not really sure why this happens, but they say that they have better chances of being okay if they are on their back. Plus, the other things you have to worry about are like having a bunch of things inside the crib, like bumper pads and stuffed animals and blankets and stuff. You have to make sure all of that's out of there so that they don't have problems. And then as far as them sleeping, newborns sleep on an average of 8 to 9 hours a day and 8 hours usually at night. So infants normally don't sleep through the night until about 3 months old, when their stomach size is increased so that they can take in more breast milk and formula. So around 6 months of age, the infant may begin to sleep 8 to 12 hours a night. So that's usually, something great for the parent. I'm sure everyone likes that more. Okay, which of the following vital signs is outside the normal range? So your answer is going to be C. Respiration should be around 30 to 60 breaths per minute. Okay, so then this gets into a little bit about nursing procedures specific to newborns and infants. So they talk about assisting with circumcision. So typically some of the nursing functions, if you were assisting with this, would be to administer Tylenol 1 hour before the procedure. Sometimes they'll do the EMLA cream as well. That can be applied to the distal half of the penis about 60 to 90 minutes before the procedure. You help position the infant on a circumcision board, which protects the arms and legs in a straddled position. The upper body should be covered to minimize heat loss. Suction should be available in case of, the baby throwing up. And then swaddling aids in increased comfort. So if you make sure you swaddle the infant, that helps. Sometimes they'll do sucrose, which is 24% sugar water solution that can help to relieve the pain. And then non-nutritive sucking can also help relieve pain. So we try to decrease environmental stimuli. And if this person is coming back to get this done and they don't get it done immediately when they're first born, then sometimes they're hospitalized for the procedure if they're older than 1 month. So after the procedure, I know we talked about this in OB, but a petroleum gauze should be applied to the head of the penis to prevent irritation from the diaper. And then you are looking for problems with bleeding, and you're frequently watching and making sure that they don't have problems with infection or bleeding. Okay, so for discharge, if you were going to discharge someone who just was circumcised, you want to talk about signs and symptoms to look for, right? So the bleeding, so persistent bleeding or blood on the diaper more than a quarter size, that's a problem. Increasing redness, fever, other signs of infection like swelling or discharge, or not urinating normally within 12 hours after the circumcision. Those are things that you would worry about. And then as far as taking care of an uncircumcised male, so you don't want to force the foreskin over the penis. Make sure the penis is cleaned meticulously to prevent infection, and do not insert the objects under the foreskin to cleanse it, such as a cotton-tipped applicator, because that can cause problems. For medication administration, children are not little adults, so pediatric dosing must be precise to ensure adequate therapeutic levels. Dosing is based on weight. When possible, caregivers should use syringes to measure and administer liquid medications. Caretakers should be discouraged from using household spoons because they may vary in size, which can lead to inaccurate dosing. Okay, so anticipatory guidance for the family of a newborn. So they talk about this pediatric medical home. This is developed, it's a developed pediatric medical home model to deliver primary care to the child and family in a coordinated and comprehensive approach. Medical homes coordinate care across the healthcare spectrum. So it's just like with adults, basically. So you have a main physician, and that physician coordinates your care. So if you need to see like a dermatologist or a mental health professional or whatever, they coordinate all of that, and they make sure that everyone talks to each other and all of the records are shared with everyone. Then this talks about umbilical cord blood banking. So umbilical cord blood banking is a fee-for-service option that stores cord blood obtained at the time of delivery to provide positive or possible future reimplantation through a cryostorage of stem cells from the cord blood. Stem cells can produce cells that can be used in the future to replace bone marrow destroyed by disease, radiation, or chemotherapy. A strict protocol must be followed in stem cell recovery. Cord blood banking is not compatible with a delay in cord clamping. Harvesting of the stem cells prevents them from returning to the infant. So my family actually did this with all three of my kids. We did this umbilical cord blood banking. So you get a hold of a company that does it ahead of time. They send you the stuff. And then when you go to the hospital to have your baby, you give the nurses your things that you got in the mail, and then they take care of it. They get the cord blood, and it gives them instructions on how to like send it to the place that you're having it banked at. So it's kind of nice. It's just like a flat fee for service that you pay like maybe monthly or something. It's not that bad. Okay, need for immunizations. The benefits and risks associated with being immunized should be discussed. Adult immunizations behavior influences how these caregivers immunize their children. So unfortunately, there's a lot of weirdness out there in the community about, getting your kids immunized. Years ago, there was some stupid study out there that was not based in any kind of reality, and it caused a lot of people to quit immunizing their kids. And obviously that's not a correct thing to do. We should all, immunize our kids. It's the better thing to do. All right, taking temperatures. To do an infant's temperature, typically they want digital, tympanic, or temporal thermometers. Rectal temperatures are taken for children younger than 3 years old in the ER, newborn nursery, and pediatric units for accuracy. For rectal temperatures, lubricate the end of a water-soluble solution and insert the rectal thermometer no more farther than a half of an inch into the rectum. For axillary temperatures, under the armpit, you place the non-lubricated end in the armpit and hold the infant's arm at his side for approximately 1 minute. And this can be used with infants 3 months or older. Signs of illness in the newborn and infant. Things that you would see that might be a red flag, so you might think they were sick. So if they have a temperature, of course, if it's, axillary temperature greater than 99.3 or a rectal temperature greater than 100.3. If they're vomiting or if they have a decrease in wet diapers, sunken or bulging fontanelles, loss of appetite, foul odor or bleeding from the cord or circumcision, increased irritability, blue or cool hands and feet, skin rash, drooling not associated with teething, refusal to lie down if 8 months of age or older. So any of those things would be things you should, get checked out. Sibling rivalry. So this can occur because of changes in family structure and routine. A lot of times this is because, an older kid is by themselves at first, and then once more kids start to happen, they're not the one that gets all the attention anymore. So encourage older children to attend sibling classes and instruct caregivers to include siblings in the supervised care of the infant as appropriate, and foster opportunities for siblings to bond with the infant. Okay, milestones or concerns or red flags. So developmental concerns. So things like no attempts by the infant to lift their head when laying face down, no improvement in head control, they don't respond to loud noises, if they're extremely floppy, lack of response to sounds or visual cues, inability to focus on a caregiver's eyes, poor weight gain, or they don't crawl by 12 months. Those are things that are concerns. And then for you to foster positive parenting skills, you want to encourage parents to talk to their infant, respond to the infant's sounds by repeating and adding words, read to the infant. This helps to develop and foster understanding of language and sounds. Sing to or play music for the infant, praise the infant and give the infant attention, spend time cuddling and holding the infant so that the infant feels cared for and secure. Play with the infant when he or she is alert and relaxed, and watch for signs of being tired or fussy so that they can take a break. All right, so then this gets into emergency care and hospitalization. So when we have to do emergency care measures, it's very stressful for everyone. So you need to make sure you stay calm, begin rescue breathing if the infant is not breathing, call 911, apply pressure with a clean cloth to any area that's bleeding. If the infant is having a seizure, lower the infant to the floor and turn his or her head to the side, and don't put anything in their mouth. Do not move a seriously injured infant unless he or she is in an unsafe situation, such as a burning house or something like that. Stay with the infant until help arrives, and then bring all medications and poisons to the emergency department. Provide an accurate history of preceding events, including the last time the child ate and what was eaten. Okay, and then with the baby that gets hospitalized. When infants or newborns require hospitalization, the pediatric nurse must be able to care for and develop nursing interventions that meet the unique needs of the infant and newborn in the hospital setting. By age 6 months, the infant becomes aware of the absence of their parent and can often sense anxiety in their parents as a result of hospitalization. So the pediatric nurse is in a unique position to attend not only to the needs of the infant, but also to the family unit. So when caring for a hospitalized infant, encourage caregivers to room in, educate caregivers on the normal development milestones and stages, noting that a hospitalized infant may regress in behavior. Encourage child or caregivers to provide security items such as the child's favorite toy or blanket. Educate caregivers on safety risks in the hospital, such as lowered crib rails, the infant's crawling on the floor, or the presence of items that may not be in the infant's home. Reinforce the importance of therapeutic play, and at 6 months of age, infants suffer separation anxiety and can be sensitive to caregiver cues. So make sure you talk to them about that. They do have someone called a child life specialist that they have in hospitals now that can come, and they're trained to work with hospitalized kids. So if they're having issues with anything, they're someone that's a good resource to come talk to them. All right, this then gets into alternative and chronic care, complementary therapies, or chronic pain stuff. Okay, so there are certain things out there that you can do, and not everyone feels the same about everything, but alternative and complementary therapies are healing therapies that are not part of the mainstream medicine, but maybe they might help slightly with something. So like infant massage is one of them. So this is something that can help stimulate organized sleep patterns, enhance growth. It can assist with colic in infants, promotes bonding with the caregiver. Music therapy is another thing that you could do. They say that it improves sucking, weight gain, sleep, recovery from painful procedures, bonding and attachment. So stuff like that could be something that might help. And then chronic care for the infant. So they say, although most infants grow and thrive, some children die in infancy. So for every 1,000 infants born, 6 will die before the age of 1. The 5 leading causes of infant deaths or chronic care needs are complications of prematurity, birth defects, maternal complications during pregnancy, SIDS, and accidents or unintentional injuries. So when we talk about safety measures for infants and newborns, there's a ton of things that we need to talk about. So one of the things they talk about is pets. So acclimate any pets to the new room setup before the baby is coming home. Make sure that the pet does not attempt to bite or unintentionally suffocate the infant, and never leave the infant alone with the pet. With drowning, never leave the infant alone in the water or near standing water. Don't leave the infant to answer the phone or doorbell. Keep the toilet lids closed and empty buckets immediately. With burns, do not hold the infant when smoking, drinking hot liquids, or cooking. Do not heat formula or breast milk in the microwave because it can cause uneven heating and may inactivate nutrients in the breast milk. You need to use sunscreen with infants when they're outside. Keep infants out of direct sunlight to prevent sunburn. Turn pot handles away from the outside of the stove because they can be pulled down. There's a lot of things with burns. With choking, don't attach pacifiers or other objects to the crib or body with a string or a cord. Keep small objects away from infants, including toys or stuffed animals with small breakaway parts. Cut or remove pull cords or blinds or drapes. Cut all foods into small, really bite-sized things so they can't choke on them. With poisoning, keep the poison control number at every phone. Keep all medicines, cleaning products, nail polish remover, anything out of reach. Take all suspected poisons to the phone when poison control is called to be able to read the ingredients to the center. Never leave an infant alone in a yard. Do not apply sunscreen or perfume creams or lotions because they will be absorbed in an infant younger than 6 months of age. Keep indoor plants out of the infant's reach as well because they could get poisoned from that. With falls, never leave the infant alone on a changing table, couch, chair, or bed. Always keep a hand on the baby. Use gates at the top of stairwells. Don't use walkers. They have resulted in serious injuries and even death if they cause the infant to fall downstairs. Educate caregivers on how young children should hold an infant and protect their heads and necks. With car seats, each state has its own specific law related to car seats. Check the age and weight limits for the seat and use only approved seats. Never put the infant in a front seat with a safety airbag. Rear-facing infant seats are used from birth up to 2 years old. Parents can contact certified child passenger safety technicians to correctly install infant car seats. With electrocution, keep cords unplugged when not needed and watch for chewing marks on electrical cords. And then for suffocation, remove excess bedding from the crib, remove stuffed toys from the crib, keep all plastic garbage bags or shopping bags out of the reach of the infant, monitor for issues in sling carriers that make the infant, make sure the infant does not get wrapped up in clothing, that the head does not fall forward, cutting off the airway. All right, and then this talks about child abuse considerations. So shaken baby syndrome is a big one. With shaken baby syndrome, head trauma results from injuries caused by vigorously shaking the baby. The anatomy of infants puts them at risk for injury from this kind of action. Most victims are infants younger than 1 year old, and the average is between 3 and 8 months. Pay special attention when choosing a babysitter. You know, research suggests that teenage fathers are more likely to cause shaken baby syndrome. You can get things like detached retinas, permanent brain damage, death. You know, there's a ton of things that can happen from that. In the book, it also has a thing about daddy boot camp. So if you do have a young father, then maybe that might be a good thing to send him to so he doesn't do anything like that. Abduction prevention. So educate the caregiver. In the hospital, infants will be banded with electronic tags to prevent abduction. Hospital staff should be properly identified with hospital badges to identify that they have access to the postpartum and newborn areas. You know, be suspicious of casual acquaintances or strangers who attempt to befriend the parent. Never leave the infant alone at home. Place the infant in the car seat in the car, lock the doors, and then load your groceries or items from the store. Call police anytime you're suspicious or concerned about the infant's safety. With sexual abuse, warning signs of sexual abuse in infants would be stained or bloody diapers, genital or rectal pain, swelling, redness, or discharge, bruises or other injuries in the genital or rectal area, excessive crying, withdrawing from others, failure to thrive. And then physical abuse, warning signs of that would be unexplained or repeated injuries such as welts, bruises, or burns, fractured skull, broken bones, spiral fractures, injuries that are unlikely given the age of the ability of the child, such as broken bones in a child too young to walk or climb, disagreement or inconsistency in parent explanation of the injury, anything like that. And then with emotional abuse, this would be things like aggressive or withdrawn behavior, shying away from physical contact with parents or adults, basic needs of food, warmth, and cuddling not met. And then with neglect, consistent failure to respond to the child's need for stimulation, nurturing, or encouragement, actively refusing to respond to the child's needs, such as refusing to show affection, infant with a malnourished appearance, anything like that. At what month should the infant have regular medical checkups and vaccinations? This would be A. The parents need to make and keep infant appointments for medical checkups and vaccinations at 2 months, 4 months, 6 months, 9 months, and 1 year. So this is kind of a big chapter, so make sure you look at this pretty closely. A lot of this we've talked about before in OB, but some things you may need to review. So some of the stuff would be things about, you know, their transition from being inside the mom to coming out. Some of the things would be about assessment of newborns, and then, you know, some developmental things that they go through. And then some of this last stuff we just talked about, you know, being in the hospital and how to take care of them and stuff, that might be a little bit new for you. So make sure you take a look at all of that. Okay, so now we're going to get into talking about toddlers and preschoolers. This is chapter 8. So some of the things that we get into here, we want to identify normal growth and development for toddlers and preschoolers, discuss the nursing assessment of toddlers and preschoolers, identify safety risks, safety interventions to minimize the risks, identify and discuss pain scales used with toddlers and preschoolers, identify appropriate nursing interventions and education regarding pain and safety for them, identify and discuss different changes or challenges faced by toddlers and preschoolers. Lots of stuff here. So this is probably, this is a cute age. It can be difficult at times, but it's a pretty cute age. Okay, so when we talk about kids in this age, most children in this age group will be able to walk alone by 15 months, begin to run, stand on their tiptoes, kick a ball, climb on furniture by age 2, all kinds of crazy stuff. Language things that they should be able to do at this point: they should know their own name, they should be able to recognize names of well-known people and things, point to objects when named by others, say 5 words by 12 months, say 50 words by 18 months, speak in 2 or 3 word sentences by age 2 years, converse using 2 or 3 sentences by age 3, and use I, me, and you by age 3. With cognitive skills, they should be able to find objects that are hidden, begin to identify and sort colors and shapes, begin to play make-believe, and begin to scribble and show preference for one hand versus the other. And then social and emotional milestones, they can, imitate others, have awareness of their self as separate from others, show affection openly, begin to display defiance, display separation anxiety until approximately the end of the 2nd year, and then express jealousy at the arrival of a new sibling. All right, so for motor development, most preschoolers are able to dress and undress themselves with assistance at age 3. They can go up and down the stairs without assistance at age 3. They can draw squares, circles, and later triangles at age 3. They can begin learning to use utensils and drinking from a cup, hop and stand on one foot for 5 to 10 seconds at age 4, throw objects overhand at age 4, and catch a bounce ball at age 4. Usually they can draw stick figures with more than 2 body parts at age 4 and use scissors at age 4. So those are some of the things they can do there. Oh, sorry, I flipped too quickly there. So with their language, they can speak clearly enough for strangers to understand them by age 5. They can speak in 4 to 5 word sentences by age 4. They can tell stories, use future tense, state their full name and address in later stages, and have concrete or literal interpretation of language. As a preschooler, they should be able to recall parts of a story, count to 10, begin to understand the concept of time, begin to use imagination and creativity, and ask why questions, which, boy, my kids constantly would ask why for everything. With social and emotional milestones, they can start to become more independent. They can be proud of their abilities and show interest in new things. They can obey rules, engage in role play well with others, try to negotiate problem solving, believe in monsters or be afraid of the dark, place importance on body integrity. Okay, so with health history, when we're taking care of a toddler, you want to get their chief complaint, see what their current signs and symptoms are, look at their family medical history, see if they have any kind of genetic disorders or chronic diseases, look at their medical history. Have they had any kind of childhood illnesses or hospitalizations or surgeries? Look at their medications. Do they have anything that they take on a normal basis? Do they have any allergies? Do their review of systems. So this means, hey, how are they eating? How are they sleeping? Are they eliminating well? And look at their social history. What's their living arrangements like? Do they go to daycare? What's their behavior like? With physical assessment, we want to look at their height when they stand, because lordosis can be a common problem in this group, so you want to check for that. You want to look at their weight with minimal clothing on in a diaper or underwear only, so that it's more accurate. And then you want to look at their head circumference. Usually this is measured for all children younger than age 2 because after age 2, it's difficult because bone growth and things affect that. You're going to look at vital signs, including heart rate, respiratory rate, temperature, pulse ox, blood pressure. And then with general assessment, you're looking at their appearance. Is it appropriate? Are they clean? Are they dressed right? Does it seem like they have any trouble hearing or seeing or with speaking? Look at their ears, eyes, nose, mouth, all of those types of things. Torso, see if there's any rashes anywhere. Look at their extremities, see if they can move, range of motion pretty well. Check for pain, all of those types of things. All right, so with visual assessment, you want to note the child's overall appearance, look at the chest for labored respirations, note the position and comfort that they put themselves in when they're having difficulty breathing. Check their skin for abnormal bruising, rash, or lesions. With auscultation, lung sounds, you want to listen to those, see if they have anything abnormal. Neck sounds, look for stridor or snoring. Heart sounds, try to see if they have any murmurs or anything like that. And then bowel sounds to see if they're present or not. Palpation, you want to check their abdomen for masses or tenderness. Pulses, make sure they have them and they're symmetrical and everything. Look at their scalp for fontanelles, which typically close by age 2. And then growth and development assessment charts. So again, those are kind of important. So you want to look at height and weight to see if they're appropriate for their age. Other things you're going to look at would be the Denver Developmental Screening Test. That's something that you do from 1 month to 6 years. And there's a couple other ones that the book mentions, but those would be something that you would do, to look at their growth and development. With safety, so according to the CDC, unintentional injury is the #1 cause of death for all children in the United States. So it's really important to talk about some of those things with the parents and everything to make sure that they understand some of those safety things they should be doing. So the top 5 leading causes of injury deaths in children would be drowning, motor vehicle accident, homicide, suffocation, and fires and burns. So the leading causes of non-fatal injuries in children would be, and this is in kids 1 to 4, this would be falls, struck by or against an object, bites and stings. And then injury death rates were highest among American Indians and Alaskan Natives, whereas rates for Caucasians and African Americans were approximately the same. Drowning was the leading cause of injury death for those 1 to 4 years old. Falls and poisonings remain highest among children between 1 and 4 as well. So things that we could do, like nursing interventions for this, you minimize falls by keeping the side rails and on the beds and cribs up. Remind caregivers to never leave the crib side if the rail is down. Check equipment regularly, like wires and cords, and make sure that all looks okay. Check the temperature of water, food, and drinks to prevent burns. Explore signs and symptoms that potentially may require referral to Child Protective Services. Educate the caregiver about basic, safety things to do at home. And install smoke and carbon monoxide detectors and ensure that they are operating by changing the batteries every 6 months. And again, some of those things that we talk to with caregivers, you talk about a lot of burn type things, right? So don't carry hot liquids around children or while holding them. Don't allow children around smaller hot appliances. Always check the temperature of water, food, and formula before you use it. So those are some of the things that you might tell them. And then with outdoor safety, child-proof swimming areas, including access to pools, ponds, and lakes. Never leave children unattended near a swimming area, even if they can swim. Use flotation devices. Never leave toys in the pool because children may be tempted to retrieve them. Always use safety or booster seats and place children in the back seat, for cars. Teach crosswalk safety. Playgrounds and unfamiliar play areas pose an increased risk for danger because of unfamiliarity of the environment. So remember that as well. At what age are most toddlers able to walk alone? This would be B. Most toddlers are able to walk alone by 15 months old. Okay, so this also gets into a little bit about pain. So pain assessment can be kind of difficult in this age group because they're young and it's hard to get them to be able to tell you exactly what's going on. So some of the things that you might see that would, make you think that they're in pain would be a furrowed brow or an open mouth type of a grimace or a lack of expression. Irritability or agitation, no vocalization or harsh, high-pitched cry. So we want to look at the quality of their pain, the causes of it, specific behaviors associated with it, and use different pain scales. Some of the pain scales that the book comes up with are the FLACC, the FLACC. This looks at faces, legs, activity, cry, consolability, and observation. So this is studied in children aged 2 months to 7 years. It's recommended for ages 1 to 5, basically, they say. So that's a good one to use. And then they have the DEGR scale and the TPPS scale. These are all talked about in your book on page 151. And of course, we all know the FACES scale. That's another one that's pretty common. All right, some other challenges that they talk about in the book is with potty training. This is a big one. So toilet training usually begins between 2 and 3 years of age. And then your kid has to be ready to do it or you're not going to have any luck. So the ability to have a dry diaper for a few hours at a time during a nap, that would be a sign that they're ready. Regularly timed bowel movements, interest in the potty or going to the potty with others. Physical ability to get to the potty and pull down their pants, ability to follow simple directions, unhappiness with feeling wet or dirty, and ability to vocalize when they want or if they have to go. Those are things that would be like, yes, they're ready to be potty trained. So some of the things they say to do, have the child practice sitting on the potty for a few minutes at a time, practice hand washing with them, teach proper use of hand sanitizer, teach the girls to wipe from front to back, and then teach boys to urinate in the sitting position first. And once they master that, then they can move on to standing. Provide encouragement in the form of praise and celebration, and do not be severe or punitive when accidents happen. With separation anxiety, this is distress that's caused by a fear of abandonment. Separation anxiety is normal. It can begin as early as 8 months of age and end as late as 3 years of age, but peaks between 10 and 18 months old. Over time, this fear lessens as the child learns that the parents come back. To reduce separation anxiety, parents and caregivers should distract the child, say goodbye, and leave quickly. The quicker you leave, the quicker the episode will end. Practice leaving at home by going to another room and saying you will be back soon. Stay calm, be consistent, and give reassurance that you will be back. Another thing that toddlers do a lot of is they throw tantrums. So this is really common in kids 1 to 4 years old. So they're just a way for kids to express their anger and frustration. So a lot of things that kids do would be, they whine or they cry or they scream. Some of them hit or kick or hold their breath. There's all kinds of crazy things they do. So when faced with a tantrum, caregivers need to stay calm and collected. Vent your frustrations verbally or physically. Venting your frustrations verbally or physically can worsen the situation. So consequences should follow poor behavior and can include a timeout in a quiet place until the child is calm. Parents should establish and maintain routines to prevent acting out. Usually these tantrums decrease in number with an increase in language skills. All right, we've already talked a little bit about sibling rivalry. So sometimes parents need to do an intervention when there's a problem with that. So you never want to choose sides between your kids. You set rules such as no name calling, pushing, or slamming of things. Separate kids in their own spaces. Sometimes that's good. Teach them to be kind to each other by encouraging, apologizing, sharing, and comforting each other when they are hurt. With nutrition, this can be a big deal with toddlers because they sometimes don't want to eat right. So sometimes toddlers are super picky and they only want to eat one thing. So that can be kind of frustrating. And then a lot of times they have problems with like when you're transitioning them to whole milk. Children 1 to 2 years of age need 2 or 3 servings of whole milk or milk products per day, and children older than 2 should drink 2 servings of skim or low-fat milk or other products. Some toddlers can still be breastfeeding. Support the breastfeeding mother or allowing privacy and bonding during feedings. Although protein is important for children in this age group, the recommended daily allowance is 13 grams a day for age 1 to 3. Snacks should be healthy enough to provide part of a child's total nutrients for the day. So give them fruits and vegetables, milk, yogurt, and cheese, nuts, peanut butter, whole grain crackers, and cereal. Let's see, what else? Dental caries. So this is a problem in kids this age as well. So you want to encourage good hygiene practices, oral hygiene. So the way that you can prevent this from happening, so you want to use a smear of toothpaste the size of a grain of rice for kids 3 to 6. Use a pea-sized amount of fluoride toothpaste in the morning and at night. Brush their teeth. Start flossing once a day when the child has 2 teeth that touch together. All right, and then you want to foster independence. So as kids get older, you want them to be able to do more and more for themselves. So teach toddlers rules and responsibilities and how to be safe. How to be a good friend by sharing, being kind and not hitting others, how to establish and keep routines so they can begin to do these things on their own. Give toddlers age-appropriate chores, allowing them to help teaches responsibility. And then you want to encourage children to bathe and dress themselves or even assist in those tasks as well. All right, and then this also mentions a little bit about safety as well. That's always going to be important with toddlers to make sure they stay safe, especially if they're starting to do more things on their own. So you're going to want to keep an extra eye on them to make sure they're doing things okay. Caregiver support. So in the hospital, when caring for a child in a hospital setting, make sure you orient the caregivers to the unit so they know where things are. Explain all procedures in a step-by-step manner. Encourage the caregiver to ask questions and express concerns. Encourage them to learn about the child's medications. Make sure they are involved in decision-making. And then remind caregivers to care for themselves because they can't be any good to their kid if they're not taking care of themselves as well. In the home, caregivers should have emergency phone numbers readily available. So they should have a poison control number, a 911, their doctor's office, all of this like readily available stuff. If they have an emergency, they can get to it really quickly. You want to educate about signs and symptoms of infections in kids. So like if they notice that their kid has a moist, productive cough, green or blood-tinged nasal discharge, or if they're pulling at their ears, that's probably a sign that there's something wrong. So those would be some things to watch for. And then also teach parents about simple first aid stuff, about how to do wound cleansing using Band-Aids and topical antibiotics. Tell them about, signs of respiratory distress. So if they see their kid breathing really fast or nasal flaring or using their accessory muscles or anything, that's a problem. And then just tell them when to call the primary care provider. And then also the difference between when to call the provider and when to call 911. And then with pediatric disaster planning, more attention has been brought to disaster planning since 9/11. So all hospitals are not equipped to provide extensive critical care to pediatric patients. So equipment standards may vary among first responders. Weight-based single-dose medications are more difficult to stockpile than adult standard medications. So hospitals that care for children are required to have appropriate size equipment with healthcare providers who can address the child's immediate needs. Child safety is the responsibility of all adults. However, it's the nurse's duty to advocate for the best care and safety for all pediatric patients. Caregivers should have a disaster plan that includes the children. For example, children should have a place to meet and phone numbers or specific family members to contact if there is an emergency. All right, toddlers eat approximately how many times a day? This is going to be A, 7 times a day, consuming more meals than snacks. Preschoolers only eat approximately 3 meals a day with quite a few snacks throughout the day. All right, so again, in this chapter, we went over quite a few things. We talked about some of the milestones that they meet as a toddler and a preschooler with their development and some of the things that they do. We talked a little bit about safety and about pain, caregiver support, and some disaster planning. Okay, so the last chapter we're going to go through is about school-age children. So we'll go ahead and see if we can get through that one. All right, so in this chapter, we are going to describe growth and development during the school-age years. We're going to identify age-specific physical assessment approaches for school-age patients, explain medical approaches for school-age patients, explain variations in nursing procedures for them. We're going to describe strategies for assessing health promotion practices among school-age patients, describe emergency care considerations for them, identify strategies to support school-aged adolescents. We're going to integrate chronic care concepts and considerations specific to the school-age population, integrate home care concepts, recognize complementary and alternative therapies, recognize child abuse considerations relevant to school-age patients. Okay, so children 6 to 12 years old are considered school age. So during these years, they're growing up at a slower rate than before, but are still accomplishing important developmental milestones. They have a wide variety of both physical and behavioral changes that are occurring with them. So some of the things that we might see with them, each child will move through each stage a little differently. Like the younger school age child will be similar to the late stage preschooler, whereas the older school age child will be more similar to an adolescent. So it's just going to be different. Some people move through stages a little quicker than others. So careful assessment and adaptability of the part of the nurse is required in caring for patients in this age group. All right, with growth and development. So vital signs, this should be, attainment of vital signs should not be difficult with this population because they can choose as appropriate which side the blood pressure cuff should be taken on, oral versus axillary temperature, and which finger to use for a pulse ox. They're pretty agreeable to all of that. Pulse oximetry values should be the same as an adult, so 93 to 100%. A fever is generally considered to be a temperature greater than 101.4. Fevers do not cause seizures, although a sudden increase in body temperature may result in a febrile seizure. With height and weight, weight and height should be taken standing unless the child has a condition where they can't stand. Children in this age group, they should gain 3 kilograms per year in weight and gain 5 centimeters a year in height. They should experience a growth spurt between 10 and 12 years for girls and around 12 years for boys. Daily fluid requirements would be based on their weight, whereas normal urine output is based on patient age and calculated by weight. With pain assessment, the nurse can choose between a few different pain scales depending on age and developmental level. Each pain assessment begins by explaining how the pain scales work and assessing the child's ability to properly use the scale. So like before, like we talked about in the other chapters, there's the FLAC scale, the FACES scale. There's different ones that you can use depending on the age of the child. All right, so with the general survey, this is like done annually. So when they come in for their appointment every year. So you're gonna look at their developmental history, their family composition, their school performance. You're gonna assess for anything like chronic pain, problems with headaches or shortness of breath or anything unusual like that. So during this, you are going to check their height, their weight, and their BMI. You're going to look at their skin. You're going to look for things like bruises or dryness, rashes, eczema, anything unusual. Abused children in this age group may fear that they have done something wrong or they have somehow deserved what's happening to them. So primary caregivers should make sure that children understand good touch versus bad touch. And then as far as their head, you're going to assess for lice, assess their hair for dryness or brittleness, assess for open lesions or signs of trauma. With their eyes, you're going to look for visual acuity to see if they have jaundice or anything weird like that with their eyes, if they need glasses or contacts. Excuse me. You're going to look at their mouth and their teeth. Do they have a lot of teeth that they lost? Do they need, braces? Are they going to see the dentist regularly? Look at their throat. Is it, midline? Are they having any difficulty swallowing or anything like that? We also are going to look at their nose to see their nasal mucosa, if they have allergies or they have nosebleeds or anything like that going on. With the different systems, as you do your review of systems, you're going to look at their cardiovascular and respiratory system. So with cardiovascular, you're going to ask for if they have any history of any kind of cardiac things going on in their family. Do they have heart murmurs? Do you hear any turbulent blood flow at the aorta or pulmonary artery? You should hear a normal S1 and S2. With respiratory, you're going to assess for asthma. Lungs should sound clear. If you don't hear that, you can, there may be a problem. So you're going to assess for skin color to note oxygenation issues with their GI system. You're going to see if they are having problems with constipation or diarrhea. You're going to look at their GU system, see if they're, peeing okay. With girls, you're going to look at their reproductive system to see if they have started their period yet. And then like neurovascular, you're going to look at their coordination and their balance, their fine motor skills. You're going to check for scoliosis with cognitive and psychological and social. Like you're going to look at, like with cognitive, you might ask them things about cause and effect. Psychological, you're looking at like Erickson's or Freud's stages. And then with social, you're looking at Kohlberg stuff about morals. So those types of things. When assessing the nose, a blue or boggy appearance of the nasal mucosa indicates what? This is going to be B. A blue or boggy appearance of the nasal mucosa indicates allergies. So that's kind of important. Okay, so physical assessment approaches, medical or medication administration. So with this, oral medicines, you know, they can take oral medicines at this age. So, you know, they might take oral liquids with an oral syringe or a medicine cup. If the medication tastes bad, sometimes you can offer a chaser afterwards of something that tastes better. Sometimes pharmacies can, like say someone has to get an antibiotic, sometimes they can flavor it nicer so it tastes better to the kid. Then with subcutaneous medications, when administering those, a lot of times they'll use that EMLA cream to kind of numb up the area so they don't hurt so bad when they get their injection. IV medicines. With this age group, medical play can be helpful when IV medications are required. A child life specialist can help explain procedures in an age-appropriate manner. Older children may be more compliant if they can make appropriate decisions, such as which side to insert the IV. Remember that the patient will still need to perform age-appropriate activities such as coloring for younger children and writing homework or crafts for older children. Distractions such as discussions about something other than that current procedure can be helpful if they are perceived by the child as authentic, calm, and positive. Okay, variations on nursing procedures. So when caring for this age group, it's important to gain the trust of the child before beginning assessment or doing procedures. Explain procedures in an age-appropriate way and do not lie if the procedure will be uncomfortable or painful. Tell the child and the parents or caregivers what you will be doing before you do it. So you look and assess the child's appearance, you talk and discuss with the child and the patients and caregivers about the history or problems, listen to what the child tells you, you touch and be non-threatening by avoiding sudden movements and staying at the level of the child whenever possible. You allow for privacy. Appropriate rewards such as stickers or small toys can be given afterwards. And then if a procedure must be performed, have the instruments ready and inform the child immediately before the procedure. Do the least invasive parts of an exam first. If the parts of the exam is invasive or painful, this will make the child feel fearful of further non-invasive, painless parts of the exam. Okay, so with health promotion, when we talk safety, school-age children are very physically active in biking, sports, and other activities. So unintentional injuries, including head injury, is the leading cause of death in this age group. So you should talk about, you know, wearing a helmet when they ride their bike or their scooter or their skateboard. You should talk about pedestrian safety, including walking on the sidewalks, looking both ways before they cross the street, walking against traffic for safety, and then also the need for adult supervision. So children are starting to have independence at this age and may be able to do many activities with less direct supervision. Children are able to play alone with adults nearby, but should not be left unsupervised for any extended periods. All right, as far as nutrition goes, school-age children have a decreased caloric requirement compared to previous stages of development. So approximately 17.4% of school-age children are obese. So BMI is defined as greater than the 95th percentile by the CDC, and another 18% are overweight. So a high BMI in children is linked with increased lipid levels, insulin levels, and blood pressure, and it could lead to atherosclerosis and obesity in adulthood. So it's good to try and get good habits when you're that age. Exercise, kids should be exercising for at least an hour a day. Encourage normal school age activities such as ball, jumping rope, bike riding, skating, and using playground equipment. Encouraging participation in school exercise programs and available sports. All right, the nurse should assess for school avoidance, refusal, and phobia. Some of the things that you might see with someone that's refusing to go to school or something would be they complain of frequent stomach aches, they refuse to attend school, they call home and try to get sent home early all the time. So in the case of school avoidance, an interdisciplinary approach should involve teachers, school counselors, parents, and primary caregivers and healthcare professionals. Homeschooling may be an option until the issue is resolved. Bullying, that's another unfortunate thing that happens all the time. So this is an aggressive interaction between individuals or between an individual and a group. The interaction is unsolicited and unwanted by the individual being harassed, and the interaction brings about psychosocial distress and is meant to bring ill feelings and fear to the individual. So various factors are associated with being a bully, a victim, or both, including age, lower socioeconomic status, parents and caregivers with high school or lower education level, poor health status, physical appearance, poor academic achievement or social adjustment, and sexual orientation. Many schools now have programs to deal with bullying and a zero tolerance and anti-bullying policy. The nurse caring for a school-age child should assess for both physical and psychological signs of bullying, help caregivers find resources to assist with that, and for children with special needs, assess the resources available at the school. All right, with substance abuse and sexual activity, you should assess for and discourage the use of alcohol, tobacco, and drugs. So a lot of schools have DARE programs that they get their kids involved in. The healthcare provider should assess children at this age for understanding and knowledge of sex. Children may be more willing to discuss this topic privately without their parents present. Sex education in schools often starts during this age range. The nurse should assess whether the caregivers, excuse me, have started to discuss sex with their older school-age children. Be aware that discussing the subject can be difficult for caregivers. Help caregivers find resources to teach their kids about creative ways to open the discussion. Sexting is a big deal anymore. So this is the practice of sending nude or explicit photos or videos or messages through a smartphone or device. Children can suffer emotional and legal consequences for sharing this type of photo with peers. Caregivers should ask their children about sexting and be aware of their child's online activities. Okay, unintentional injuries and cancer are two leading causes of death in children 5 to 14 years old. When a child has been injured, the family often sees a physician as the point person, but he or she is often unavailable to talk with the family during the crisis while providing and directing the care. For this reason, child life specialists, social workers, and chaplains should be available to help out with this. And then when they talk about family-centered care, This is making sure everyone is involved in the care, that everyone has a say, and you have someone to talk to when you need it. Okay, with acute care hospitalization, um, when a child requires acute care, the environment of care depends on the facility. In any situation, it's beneficial to allow the child and family in an area for their own items. The room should be a safe area for the child, with all invasive and painful procedures performed in a treatment room. This helps prevent child and caregiver fear when clinicians enter the room. Educate parents and caregivers as to the reason for the use of the treatment room. When possible, older school-age children can decide whether they want to go to the treatment room or have the procedure at the bedside. Encourage caregivers to have an active role in caring for their child. Um, they can always bring things from home to help the child feel more comfortable. Allow walks with caregivers when possible. Encourage visitation of siblings. Encourage siblings admitted together to get a double room or be placed next to each other to facilitate care for the primary caregivers and help the children cope with the hospitalization. So when this talks about the child life specialist, they do a number of different things. So they can prepare kids for medical procedures, including medical play. So like they might use a doll to help a child act out a procedure to decrease their anxiety. They can accompany a school-age child to a procedure or test to provide distraction and coaching. They can plan celebrations for children who are in the hospital for like milestones, like their birthday or a holiday or something. They can offer music or art therapy to provide distraction. They can offer therapeutic puppetry, coordinating an activity room where children can play with toys and games or participate in organized activities. So they're kind of nice. They're a really good support to kids and parents when they're there. So school-age children express individual preferences and personalities. Nurses can help patients in this age group make appropriate choices, offering a choice the child does not have, such as whether to take a medication. Older school-age children seek more autonomy and may want to assist with their own care. Nurses should answer questions honestly at an age-appropriate level. Keep in mind that younger children at this age group are concrete thinkers, so avoid using inaccurate terms like a little stick for a needle. So this talks about care of the chronically ill child. So nurses care for the chronically ill pediatric patients should consider normalization of lifestyle limitations and reaching milestones. Children with chronic illnesses should be praised for attaining milestones and may do so later than peers. Resources such as physical and occupational therapy can assist in these accomplishments. As far as the primary caregiver goes, most caregivers will have a very active role in the care of their chronically ill child and possess extensive knowledge of his or her conditions, treatments, and medications. As in other areas of nursing, family-centered care is paramount. Children with chronic conditions may be unable to communicate in the same manner or to the same extent as other children. Caregivers will notice changes in their child that nurses may not. Caregiver fatigue is common among families with a child with a chronic illness, so these parents must devote significantly more time to caring for their child than those of their healthy children. This can have negative effects on their family and be very stressful. Marital stress and divorce can be common in cases like this. So to combat the effects of caregiver fatigue, caregivers must have a good support network and apply an ability to participate in activities that promote stress relief. So that's really important. What is Emla cream used for? The answer is A. It's an eutetic mixture of local anesthetics. Medicated cream, when appropriate, to prevent pain associated with needle insertion intravenous cannulation, and superficial surgery on the skin and genital mucous membranes. All right, so in this stuff, we talked about quite a bit. So school-age children are a little bit different because you can treat them a little bit more like an adult in a way with their vitals and stuff like that. But they still are quite different from like the younger school age compared to the older school aged. So we also talked about how to promote health in them, emergency care, acute hospitalization, and chronically ill hospitalization. So this was kind of a long one, so hopefully you guys listen to this and can take some notes. Make sure that you spend some time in this stuff and make sure you feel really good in it. Look in your ATI pediatric book because there's quite a bit in there about these things, and it can like make things a little simpler for you. Hopefully you got all this okay. If you have any questions or anything, you can email me. Thanks.